Good evening, everyone. Welcome to the second PSD ERC for the fiscal year 2020 to 2021. I'm Dr. Angela Jajakusuma, one of the moderator for tonight's activity. We will start our meeting with the invocation and the national anthem.
Mga kababayan, ang pambansang awit ng Pilipinas. Kayang magiliw, pero sa silanganan, alam ng puso, sa liit mo'y buhay. Lupang hinirang, kuyagan ang magiting, sa mandulupin, di ka pasisigil, sa nalatang tulog sa simoy at sa langit mo pagkaw, ay nilatang tulang awit sa pagkayang minamahal. Ang isang ang matawad, ngunit ang buhay na nagtitigil, mapituloy at araw na kailan ang kanyang magtitigil. Luman ang araw ng walhagit pagsinta, buhay ay langit sa piling mo. Aming ligaya ng pagkay panghabi, ang mamatay ng dahil sa'yo.
To give us the welcome remarks, may I call on the President of the PSDE, Dr. Benjamin Gerardo Perez.
Good afternoon. Welcome to the second of the ERC series that we have for this year. As you know, this is a new method we are doing where it's all webinars with just to the pandemic that we have right now. Although rest assured, as soon as things can be more normal, we will be having more face-to-face. This webinar by UPPGH and the MD and Manila doctors promises to be a very interesting one with many to two important and good cases. So welcome again to this ERC for this month of July. I hope you will enjoy it and have a good afternoon.
Thank you, Dr. Perez. For the opening remarks, please welcome the Assistant Section Head of UPPGH and past President of the PSG and PSDE, Dr. Peter C.
On behalf of the UPPGH Medical Center section of gastroenterology, I would like to welcome all of you to this afternoon's conference. Many years ago, when I was still a fellow, I was also attending this ERC. Fast forward, today the conference is being conducted through Zoom with you attending right inside your home. Perhaps you are still wearing your pajamas. At today's conference, our fellows have presented or prepared a very interesting case. Interesting because the case is common yet bizarre, strange at the same time, familiar. Hopefully, at the end of the presentation, you'll be able to decide who between the endoscopist and the lesion is David and who is Goliath. So without further ado, may I call on Dr. Josh Torres to present the case and Dr. Angela Juju Kusuma to moderate the discussion. Thank you.
Thank you, Dr. C. But before we start with our cases, we have the chairman of the GI unit of Manila Doctors Hospital and past president of PSDE, Dr. Marie Michelle Cloa, to give her opening remarks.
Hi, good evening. Today I'm here to welcome you all with my new hat. I am now the Chief of Section of the Manila Doctors Hospital Section of Gastroenterology and Digestive Endoscopy. It is our pleasure here at MDH SGDE to welcome you all and to be one of the presenters for tonight's ERC. I welcome not only our fellows in training, also the chairs and the TOs of the different training hospitals, as well as colleagues, members of PSDE watching us tonight. So I hope that everybody will appreciate what we have prepared for today. I also thank foremost also the moderators and resource persons who are helping us tonight. Again, thank you and please enjoy the evening.
Thank you, Dr. Cloa. At this time, I would like to introduce the reactors to the cases for this evening's ERC. Our first reactor is Dr. Esperanza Gray Santi from De La Salle University Medical Center. She graduated Doctor of Medicine from De La Salle Health Science Institute, had her training in internal medicine at De La Salle University Medical Center, and fellowship in gastroenterology at the University of Santo Tomas Hospital. She pursued advanced and therapeutic endoscopy and endoscopic oncology in University of Malaya Medical Center and Showa University Northern Yokohama Hospital, respectively. Next is Dr. Patricia Ann Prodigalidad from Makati Medical Center. She graduated Doctor of Medicine from the University of the Philippines and had her training in internal medicine and gastroenterology at the UPPGH. She had her advanced therapeutic endoscopy and endosonography and capsule endoscopy training at California Pacific Medical Center in San Francisco. She is currently the treasurer of PSDE. I would also like to introduce our resource speaker in radiology, Dr. Rosana Fragante from UPPGH. She graduated medicine from the University of the Philippines, had her residency in diagnostic radiology, and fellowship in ultrasound, CT, and MRI at UPPGH. She is currently the Vice Chair for Graduate Studies of the Department of Radiology of UPPGH. So now, we come to the case presentation. As a reminder to the attendees, only the reactors are allowed to ask questions verbally, and they need to click on the raise hand button in the Zoom app to be allowed to ask their questions. All others have their microphones muted, so please direct any questions to the chat box in the lower part of your screen. We will try our best to answer them, but it may not be possible to answer them all due to time constraints. Also, since the purpose of the ERC is to highlight the correlation between endoscopy and radiology, the entire case may not be presented like a regular case conference. So to present the first case from UPPGH, we have Dr. Adrian Bonghanoy and Dr. Joshua Torres.
Good afternoon. Is everyone seeing my presentation? Okay, okay. Once again, good afternoon. I'm Adrian Bonghanoy, and I'll be presenting our first case. And thank you for attending our endoscopic radiologic conference entitled David and Goliath. So our first case is the Goliath of this presentation, and the bulk of my presentation will require showing of videos. And to allow airing of the videos without interruption, I'll be turning off my own videos. Okay, these are the objectives of this presentation. This is a case of a 46-year-old male who had a chief complaint of difficulty swallowing solid foods. So this started 3 months prior to admission with solid dysphagia associated with globus symptoms, weight loss, fatigue, and occasional blood tinge postprandial vomiting. Patient initially sought consult to a general surgeon and a chest CT scan was requested, which showed an esophageal mass. Thus, patient was then advised admission and was referred to our service. Patient is a diagnosed case of schizophrenia with good compliance with his maintenance medication, and he is currently on treatment for pulmonary tuberculosis since January 3 of this year. Otherwise, he has no other chronic comorbidities, no previous hospitalization, endoscopies, and surgeries. He has no known allergies and denies any vices and risky sexual behaviors. And family history was unremarkable. Our service seeing the patient alert, oriented, ambulatory, febrile, and not in distress, with stable vital signs, although heart rate was on the high side at about 100 beats per minute. BMI was low normal, yet weight loss was prominent from baseline according to the patient. Physical examination showed a pale palpebral conjunctiva with no apparent oropharyngeal lesions and palpable mass or lymph nodes. Abdominal examination and the rest of the PE were unremarkable. For the review of systems, patient had GI-related and non-specific symptoms of dysphagia, fatigue, weight loss, and occasional postprandial vomiting. Other than slight pallor, other systems were unremarkable. These are our salient points of the case. We have a 46-year-old male with 3 months history of solid dysphagia, globus symptoms, weight loss, and fatigue. He is currently being treated for pulmonary tuberculosis, otherwise has no chronic comorbidities. Physical examination showed pale or pallor. They were unremarkable, otherwise unremarkable PE. Lastly, workup showed esophageal mass on chest CT scan with IV contrast.
Okay. Before we proceed, may we launch the first poll question? So for the first question, what are the possible etiologies for an esophageal mass? A. Leiomyoma, B. Squamous cell carcinoma, C. Adenocarcinoma, D. All of the above. Let's click in your answers. May we have the poll results? So majority answered all of the above. So Adrian, please proceed.
Okay, so on admission, we considered, yes, the esophageal mass as either benign, like an esophageal leiomyoma, a malignant, either a squamous cell or adenocarcinoma, or infectious in nature, like esophageal tuberculosis. So we saw the patient with complaints of solid dysphagia and fatigue. There were no recent episodes of vomiting. Physical examination was again, general unremarkable, except for slight pallor. So we started patient with ONS for nutritional buildup and IV fluid hydration. Workup included CBC, bleeding parameters, basic clinical chemistries, and 12-lead ECG and chest X-ray. Patient was referred to our service for diagnostic EGD and biopsy. So these were the lab results showing anemia with a hemoglobin of 85 with low cell indices, while the rest of the results were within normal limits. This is the chest X-ray in PA and lateral view, showing a well-defined convex forming in homogeneous opacity noted in the right paratracheal area, localized to the superior to posterior mediastinum on lateral view, approximately measuring 6.2 by 6.3 by 6.6 centimeters. It anteriorly displaces the trachea with narrowing of the AP diameter. So this right paratracheal focus described likely represents the known esophageal mass in this patient.
So before we proceed, let's have the second poll question. So the question is, an esophageal malignancy may present with the following on CT scan imaging except A, esophageal wall thickening or irregularity, B, periesophageal soft tissue stranding, bronchial invasion with displacement of the airway, D, none of the above. Please click in your answers. May we have the poll result? So most answered none of the above. So to help us with the CT scan finding, may we call on Dr. Fragante for the discussion.
Okay, good afternoon. So what we actually see is this large mass. Do you see it, everyone? So this is the sagittal section. This is the transverse section. And this is the coronal. So I will magnify it. Note that it's actually in the esophagus. This is the trachea, which is pushed anteriorly. This is the esophagus, wherein you have the dilated portion and it's air-filled. And you see a lobulated, well-defined mass. As we go clearly, we are going downwards. You see that you had some obliteration of that air column. And this is now the portion also of the mass at the level of already of the carina. And just behind, this is already the level of your pulmonary veins. You see portion of the mass. So the mass measures approximately 3.5 by 5.5 by 26.5 meters. The length is actually the 26.5. As we could see in this case, the mass is actually hypodense. It's not enhancing, it's partially enhancing. And if you look at the walls of the esophagus, anterior and posterior to the mass, the walls actually are smooth. This mass most likely has an attachment at the posterior aspect of the esophagus. So this kind of mass appears to be a benign lesion in the sense that you have well-defined borders. It has an attachment, but no actual infiltration into the trachea and no enlarged lymph nodes adjacent to the mass.
Thank you, Dr. Fragante, for explaining to us the CT scan findings of the patient. So let me continue with my presentation. Sorry for the technical difficulties. No, it's not showing. Okay, sorry for that. So, I'll be presenting the initial diagnostic EGD now, which was the first EGD in this patient. The patient had a total of 3 EGDs throughout the course of his hospital stay. Once again, this is the first EGD with this clip showing the large esophageal mass. This is the upper esophageal sphincter manifesting its converging mucosal folds, and the mass is in the upper esophagus with a broad base with its top located at 20 centimeters from the incisors with normal overlying mucosa. As you can see, the esophagus is dilated with poor peristalsis. So the pedunculated mass was noted to span from 20 centimeters to 32 centimeters from the oral incisors, causing a luminal narrowing at the entire length of the esophagus, but the gastroscope was still able to advance. The distal portion of the said lesion was necrotic and ulcerated with minimal bleeding, which may explain the anemia present in this patient. Narrowband imaging was not done for this patient, and the endoscopist at that time was convinced radiologically and endoscopically that the lesion was benign. However, biopsies, of course, were still taken to confirm our diagnosis and rule out other differential diagnoses. And the rest of the stomach and proximal duodenum were unremarkable.
Okay, before we proceed, let's see the third poll question. So based on the endoscopic findings, what is the most plausible diagnosis for the esophageal mass? A. Fibrovascular polyp, B. Leiomyoma, C. Squamous cell carcinoma, D. Adenocarcinoma. Please click in your answers. Please show the poll result. So it's a close choice between a fibrovascular polyp and a leiomyoma. So before we proceed with the subsequent EGD, do our attendees or reactors have any questions at this point? If none, then Adrian, please proceed with your presentation.
Okay, so the final biopsy showed a fibrovascular polyp. And these are the photomicrographs of the samples taken from the mass fixed on H&E stain. And the histological appearance shows a stratified squamous epithelial lining as indicated by the black arrows, and with the fibrovascular stroma as highlighted by the red box. All are consistent with the fibrovascular polyp. Considering the overall findings and possible technical concerns on future interventions, options that were entertained for the removal of such mass is through endoscopy or open surgery. And therefore, no specific guidelines based on reviews in the management of fibrovascular polyps. Therefore, management decisions are often done in a case-to-case basis, and most importantly, the patient's decision. We provided these risks and benefits for endoscopic resection. After giving the patient with all this information, the patient opted for endoscopic resection. We then proceeded to do an endoscopic esophageal polypectomy for this case. Prior to endoscopic polypectomy, the team discussed our peri-procedural approach to the case, and we discussed that the patient will be intubated and placed on general anesthesia, and a gastroscope will be used with CO2 insufflation. These were the polypectomy technique considered: endoloop assisted, clip assisted, and by utilizing endoscopic submucosal dissection techniques. Though the visibility of the first two procedures is problematic due to the large size of the polyp, it will be technically difficult, and a clip-assisted polypectomy may as well be difficult due to its broad base. And then, therefore, we opted to attempt to do a hat snare polypectomy initially, and we anticipated more than usual bleeding since we weren't able to prophylactically apply and do loop or hemoclip. So we prepared a hemostatic forceps or coagaspers. However, despite multiple attempts, we weren't able to fit the snare through the polyp head. Therefore, we proceeded to using the ESD technique. I will now be showing video clips on the polypectomy and retrieval attempts of the polyp on the succeeding slides. For reference, this is the second EGD performed out of the 3 EGDs done for this patient. So this is a retroflexed view showing the distal esophagus with the head of the polyp seen at the left lower side of the screen and the scope on the upper part of the screen. The clip shows the attempts to cut the polyp using the snare. The goal was to encircle the polyp with a snare with eventual access of the base of the polyp upon scope withdrawal, allowing polyp resection. So as we can see, the polyp head was too large and measured approximately 3 centimeters by 5 centimeters. So despite multiple attempts in the application of the snare, there is difficulty in securing the tip of the polyp within the snare. Brought about, of course, the size, extensive size, and the initial plan was subsequently abandoned. Since snare polypectomy was not successful, we proceeded as planned to polypectomy borrowing ESD technique. We used the Olympus dual knife in cutting. It has an easy two-step adjustment, a retractive knife for marking and hemostasis, and an extended knife for incision and dissection. In this clip, we are now seeing the base of the stalk at the proximal esophagus. Initially, we injected mixed gelofuscin solution with epinephrine, making removal easier to reduce bleeding. And an initial mucosal incision was done, followed by gradual dissection at its base using dual knife. On dissection, there was or were frequent episodes of bleeding, which is expected since this is a fibrovascular polyp. Dual knife was used initially for hemostasis, yet still with inadequate control of bleeding on further dissection. So subsequently, we then used hemostatic forceps, the coagasper forceps, to control the bleeding. The dissection was continued, and this clip shows the final dissection to complete the polypectomy, which was done in 2 hours and 30 minutes, showing its advantage in terms of OR and anesthesia time. However, the actual dilemma in this case.
Sorry, Adrian, before you proceed, we have a number of questions from our reactor and the attendees. So we have a question from Dr. Santi. He's asking what the size of the snare used was.
The size of the snare largest is 33 millimeters.
Okay, and
so we tried in the attempt to actually try snare polypectomy for this case.
The next question is from Dr. Carlo Lazaro. So he's asking, parallel to that, how large is the polyp?
In endoscopic view or based on CT scan as well, on AP diameter approximately 3 centimeters, and transverse diameter was 5 centimeters.
So Dr. Virgilio Banyas also has a comment. So he says that would it be helpful to inject epinephrine into the head of the polyp to shrink it since it is vascular and thereby facilitates snare polypectomy?
I'm sorry.
So injecting the head of the polyp to shrink it to facilitate ensnarement and subsequent resection.
It wasn't done because the whole length of the, if we were to inject epinephrine on the tip of the polyp, the whole length, it's a very long polyp. So not sure that the issue there was removal of the polyp. So the tip wasn't the biggest part, most likely. Actually, from the tip until the middle part was actually large enough. The base was the only part that was actually more or less be smaller in diameter. So the rest of the polyp was really large. general. So injecting epinephrine from that head probably might not even be successful to retrieve the polyp at this point.
So another question from Dr. Carlo Lazaro: will an EUS-free procedure would have been helpful?
Yes, for endoscopic ultrasound, it's very useful in the sense that we are able to check the stop for vascularity. It will assist us in where the large vessels are in dissection. However, due to the size of the polyp, we might not be able to get that accurate data because of the size of the polyp. No, so the endoscopist opted not to do the EOS.
Okay, thank you, Adrian. Please proceed with your presentation.
Thank you. So this is the next part of my presentation on the polyp retrieval. So, however, the actual dilemma again was not the dissection or excision of the polyp, but the retrieval. So from here on, we'll be showing clips on how retrieval of the tumor was attempted. So this is still part of the second EGD with a total time of polyp retrieval of 3 hours. So we performed 8 maneuvers to remove the polyp out of the esophagus, and we'll be showing video clips of each on the succeeding slides. This clip shows the attempt to extract the polyp out of the esophagus using snare. We are now seeing the excised base of the polyp. So I've mentioned which is a smaller in diameter and was easily secured. However, due to the size of the polyp, beyond that, it can't go beyond the upper esophagus and exit the upper esophageal sphincter. So for this clip, this time we are viewing the polyp head on the triplex view. So the endoscopist actually tried to pull the polyp into the stomach. So we used 33, so it has a 3 centimeter diameter at some point. However, due to the size of the polyp in general, technical difficulties, we were not able to do traction. You are again seeing the retroflex view of the polyp. Since we were not able to secure the polyp head using snare, we then switched to rat tooth forceps to pull the polyp into the stomach. So we were able to grasp the polyp easily. However, due to the size again of the polyp, we weren't able to. In this next clip, you are now seeing the excised base of the polyp. So we also tried to use the rat tooth to do it, like the snare per RM extraction. So still, for the same reason, it cannot go beyond the upper esophagus and through the upper esophageal sphincter. To assist us with the extraction of the polyp using rat tooth forceps, we instill canola oil to lubricate the lumen. We use canola oil since it's edible and safe. However, despite its addition, we were still not able to successfully retrieve the polyp per RM. So after lubricating the lumen, we attempted to extract the polyp by switching to a dual channel therapeutic scope using 2 rat tooth forceps. We are again extracting the polyp from the base and out per RM. So, however, despite 2 grasping instruments combined with torsion, it remains to be stopped at the upper esophagus, just below the upper esophageal sphincter. So the team thought of doing piecemeal resection at some point of the excised polyp, yet this was not pursued due to a high theoretical risk of injury to the esophageal wall and use of cutting. Furthermore, due to the size of the tumor, it will entail longer endoscopic time, increasing possible procedural complications. And so the team decided also on an intraprocedural referral to ORL or ENT for possible assistance on polyp extraction. Rigid esophagoscopy was utilized with multiple attempts of retrieval by oral service. However, the polyp unfortunately was still not removed. So we had an intraprocedural multidisciplinary conference as well with oral service, GS surgery, anesthesia, and a joint decision was actually made to defer polyp extraction and allow mass to shrink first. With this, patient does not have to undergo a major surgery, and a second look endoscopy to retrieve the polyp will be done after 24 hours to prevent digestion of the polyp. However, due to problems with obtaining consent and logistics, and we failed to do the AGD as planned. So, however, here, prior to leaving the polyp in situ, since the polyp was in the upper esophageal near the sphincter or upper esophagus, we push the polyp distally to decrease patient discomfort from an upper foreign body sensation. So, or worst case scenario, upper airway obstruction. So, we also attempted to push the polyp through the CEJ, but as expected, it did not permit passage of the polyp distally. So finally, we ensured that there was adequate luminal diameter for feeding liquids and there was no bleeding. Not seen in this video, unfortunately. The resection base did not show any active bleeding, muscular injury, or superficial large vessels prior to the termination of the procedure. So post-excision, patient only complained of mild discomfort on swallowing that gradually improved. Patient was started on clear liquids and gradually progressed to full diet in 72 hours. Serial CBCs were taken for any bleeding post-excision. Fortunately, there were no untoward events such as bleeding or hospital-acquired infection that occurred. After after 2 days, the patient underwent second loop endoscopy for the removal of the shrunken polyp. This is the third and final EGD done for this patient. So, however, we completed the EGD with no signs of the polyp in the esophagus and stomach and the proximal duodenum. Most likely, the polyp has already passed out distally. And this is the base of the polyp. It was inspected with good healing and no signs of bleeding. So patient was discharged, now able to tolerate full diet, and patient was advised to follow up for surveillance endoscopy for a year or earlier maybe if there are recurrence of symptoms. Okay. So we'll be proceeding to the discussion of our case. If there are no.
Yeah. Hi, Josh. So just to add to Adrian's discussion, we conferred with the endoscopist. We forgot to mention, sorry, that we actually tried injecting epinephrine to actually all areas, including the head of the polyp, but it just really failed to shrink despite the injection of epinephrine. So that made it even more difficult to extract the polyp because the polyp failed to shrink in size.
So before we proceed with the discussion, there are a number of questions in our chat box. So let me go through them one by one. So Dr. Manly Uy is asking, would an overtube help in the polyp retrieval?
Okay, the overtube, what we have here available is 1.5 centimeters in diameter.
Okay, so sorry, I was on unmute. The overtube we have available here is 1.5 centimeters in diameter. So the mass actually was 3 centimeters by 5 centimeters. So we didn't use the overtube because it's technically about 2 to 3 times size of the overtube.
So another question from Dr. Virgilio Banyes. Would it be possible to do a piecemeal resection of the polyp inside the stomach and use overtube to facilitate the retrieval?
Yes, actually, it was contemplated at some point. I mean, the team considered it, but due to the theoretical risk of esophageal injury inducing cutting in that lumen, and also the size of the polyp will entail a longer endoscopic time, so we opted not to do the piecemeal resection for this case.
All right, thank you, Adrian. Now we proceed with the discussion.
Hi, good evening. I hope everyone is in good health and safe at home. I am Dr. Joshua Torres, another first-year fellow of the Division of Gastroenterology of the Philippine General Hospital. So we now proceed to a brief discussion on fibrovascular polyps of the esophagus. This would be my outline for discussion. Fibrovascular polyps are first and foremost a type of benign esophageal tumor. These have been generally classified either based on the cell type or based on the location of the tumor with respect to the lumen or the esophageal wall. Fibrovascular polyps are epithelial, intraluminal polyps of the esophagus. Benign tumors of the esophagus are quite rare, with autopsy prevalences of these tumors as little as 0.17 to 0.59%. And malignant esophageal tumors were found to be about 5 times more common than benign tumors. Most esophageal tumors are commonly found in the middle and distal thirds of the esophagus, interestingly, except for FVPs, which are more common in the upper third. Historically, fibrovascular polyps have also been referred to as fibroepithelial polyps, fibromas, fibrolipomas, or fibromyxomas. These entities have now been formally termed by the WHO as a fibrovascular polyp. This tumor derives its name from its fibrous stroma with vascular components, including variable amounts of myxoid and adipose tissue. They are covered by normal squamous epithelium, and they are thus prone to misdiagnosis during routine endoscopy, especially if it's not suspected. Fibrovascular polyps typically start as small mucosal tumors at the level of the pharyngoesophageal junction, often at the Lammer-Heckman triangle, which is this area. So in this area, below the cricopharyngeus muscle, the mucosal and submucosal tissues are loose and redundant with less muscular support. So it is hypothesized that these features allow the mucosa to be pulled downward due to the peristalsis of the esophagus upon swallowing of food boluses. The result is a slow-growing pedunculated tumor that can often extend caudad into the lower esophagus or the stomach, or prolapse to the oropharynx. At this point, especially if it causes symptoms just by its enormous size, the tumor has been referred to as a giant fibrovascular polyp in literature. The rate for such a polyp to grow is actually unknown, but in patients in whom the polyp recurred, they took around 2 years to grow to a length of about 6 to as long as 20 centimeters. While benign esophageal tumors are rare in themselves, FVPs account for only 0.5 to 1% of these, but they are considered to be the most common intraluminally. They are found to be common in middle-aged and elderly men, reaching sizes as large as 20 centimeters in length. Fibrovascular polyps are often asymptomatic until they are large enough to cause symptoms, usually at a size of, based on studies, around 7 centimeters or longer. The most frequent symptom is dysphagia, occurring in around 7 to as much as 9 out of 10 patients. In our patient, he presented with the following, highlighted in red. So he presented with dysphagia, a globus sensation or feeling of a lump in the throat, weight loss, and iron deficiency anemia, as well as some vomiting. The most dreaded complication of FVPs reported in literature is actually death by asphyxiation due to impaction of a polyp in the glottis or the airway. A diagnosis of an FVP is made, first of all, through a thorough history and physical examination, and is then confirmed through diagnostic tests. Traditionally, esophageal tumors have been evaluated through a barium swallow or an upper endoscopy. In the barium swallow, it is seen as a large, smooth, sausage-shaped intraluminal area of defect arising usually from the upper esophagus. However, it sometimes cannot demonstrate the pedicle of the tumor well, and it provides little information on the vascularity of the tumor, which actually proves to be a very important component in treatment planning. Through upper endoscopy, it can be spotted as a fleshy pedunculated mass with a smooth surface of normal-looking mucosa arising from the upper esophagus. Though sometimes it can present with areas of necrosis or friability on the surface, such as this in this picture, which is actually an actual picture of a portion of the patient's polyp in our case. Some factors can make FVPs be missed by a novice endoscopist, such as the normal-looking surface of the polyp and the narrow lumen of the esophagus. The upper esophagus is a notorious area for novice endoscopists like us to miss these lesions, and careful inspection of this area upon insertion and withdrawal of the scope is emphasized. Our patient had a CT scan with contrast as part of his evaluation for dysphagia. Modern imaging modalities such as the CT scan and the MRI done with contrast studies are highly useful in preoperative evaluation of FVPs. Information on the location of the peduncle and the polyp's vascularity can be obtained through these modalities. And these are important considerations in the approach to how these tumors would be resected. Our radiologist, Dr. Fragante, has also educated us earlier in the role of imaging in differentiating a benign versus a malignant esophageal tumor. The EUS, this was also asked earlier in one of the questions in the chat box. So the EUS can also be a useful adjunct in the evaluation of FVPs, providing us information on the size, the vascularity, and the location of the origin of the polyp stalk with respect to the esophageal wall. In our patient, however, while ideal, an EUS was not done during the first diagnostic endoscopy, as was mentioned, due to the massive size of the tumor causing a great degree of luminal narrowing, through which an echo endoscope, which is quite a larger endoscope compared to our standard gastroscope, might be quite hard to pass. So eventually it was not done. Lastly, specimen must be sent for histopathology in order to confirm the histologic diagnosis of an FVP and to rule out the other differential diagnoses, such as those listed on the right of this slide, but is not exhaustive, and especially to exclude the presence of malignancy. The two most common benign esophageal tumors are leiomyomas, based on literature, which actually was our primary differential at first for this case, and squamous papillomas, another intraluminal epithelial benign tumor of the esophagus. The features listed above have been seen in the histopath slides taken from our patient in the first endoscopy. Due to its rarity, there are no guidelines in the management of FVPs. As such, management decisions are often done in a case-to-case basis. The treatment of asymptomatic or incidentally found polyps of the esophagus is still a subject of debate. No studies have yet been performed to compare the outcomes of polyps which are observed or resected early. Meanwhile, the mainstay of treatment for symptomatic FVPs is resection. Resection immediately relieves the symptoms caused by the massive size of the polyp, and more importantly, it eliminates the risk of life-threatening asphyxiation brought about by impaction of the polyp on the airway. As the limits of the practice of endoscopy get pushed further and further with advancements in technology and technique, the line dividing endoscopy and surgery in polyp resection is getting actually more and more blurred as we speak. After reviewing existing literature, we have summarized the factors to consider in terms of how we approach these patients, which are, so first, the tumor characteristics, number two, the expertise available, and three, patient-based factors. The two important tumor characteristics to consider are the vascularity of the tumor and the size of the tumor, especially of the pedicle. Endoscopic resection can be strongly considered if the tumor has a simple pattern of vascularity with the pedicle narrow enough to allow adequate hemostasis upon resection. Tumors with wide bases and complex vascularity patterns have been suggested to be better off, based on literature, to be resected surgically. It is also important to consider the expertise of the endoscopist who is planning to perform the resection. Several case reports have also utilized and favorably recommended a multidisciplinary approach to management to include our friends from surgery, laryngology, and anesthesia for a more well-rounded approach to management, especially of complex cases or very large polyps. Lastly, we must never forget to consider the clinical profile of our patients, as well as the patient's preferences after thoroughly discussing with them the risks and benefits of both treatment approaches. Speaking of risks and benefits of an endoscopic procedure, endoscopic resection allows the patient to avoid surgery and its possible perioperative complications associated. In uncomplicated cases, it usually connotes shorter OR times, a quicker return to a regular diet, and shorter hospital stay. However, especially for giant polyps or complicated cases, there is a risk of airway compromise during resection and even during the retrieval of the polyp after resection. Moreover, complex cases may lead to longer instead of shorter OR times, which also has its share of potential complications and additional patient discomfort. For cases that may be deemed too complex or too large for safe and adequate endoscopic removal, surgery is warranted. These are the approaches that have been suggested and have been used based on literature, depending on the characteristics and the location of the polyp. So for our patient, for which the polyp is located at around 20 to 32 centimeters from the incisors based on the diagnostic endoscopy, we might be looking at a thoracotomy approach for this patient, knowing that at that level, it would be below the thoracic inlet already. This is quite a morbid procedure, and this might have been one of the factors that was considered by the patient upon deciding to defer or to not consent with surgery for extraction of the polyp after resection. Tracheostomy is rarely performed as a life-saving measure to restore airway patency from an FVP causing asphyxiation. In terms of prognosis for giant FVPs are after resection are generally good. Mortality came from asphyxiation based on literature due to a large mass obstructing the airways, as was previously mentioned. Recurrence of these polyps is quite uncommon, but has been reported in literature as well, sometimes even occurring multiple times in a single patient. Malignant transformation is extremely rare, with reports occurring as squamous cell carcinoma or epidermoid carcinoma occurring on the surface of the tumors, found histopathologically after doing an excision biopsy, or as a liposarcoma within the lipoid components. So this stresses the point of doing histopathologic studies on whole specimen, because some of these reported malignancies have only been seen upon doing a complete histopathology workup with the whole tumor. So in summary, we have the following take-home points. Benign esophageal tumors, including FVPs, are a rare but possible cause of dysphagia and should be part of our differentials. Symptoms of these tumors are usually dictated by their giant sizes. These tumors can be missed by novice endoscopists like us on upper endoscopy, and a careful examination could not be overemphasized. Aside from a barium swallow or upper endoscopy, modern imaging modalities such as the CT, the MRI, or EUS are valuable in treatment planning. Histopathology of the entire polyp is suggested to confirm our diagnosis and to rule out the presence of an underlying malignancy. And a multidisciplinary approach and patient-centered approach to management is best for complex cases, such as those involving very large polyps. So with these points, on behalf of the team, we would like to thank everyone for listening.
Thank you, Adrian and Joshua. Before we hand over the mic to our reactors, we have a couple of questions from our attendees. So Dr. Carlo Lazaro is asking, in retrospect, would surgical management be a better option?
It would be not as straightforward as that, sir. It would really be a discussion between the risks and benefits of each treatment approach, because based on the location of the tumor, we would have to employ likely a thoracotomy approach to just retrieval of the polyp. The polyp is located at 20 to 32 centimeters from the incisor, so that would be located, and it was seen on CT and X-ray that it really was located below the thoracic inlet. So that might be quite a morbid surgery just for retrieval of such a benign polyp. So, but in literature, they have reported that resection was on resection using a thoracotomy approach, it actually yielded the least occurrence of recurrences of these polyps compared to like a transcervical approach or an endoscopic approach. So, but again, the patient opted to be more conservative and opted to just leave the tumor while being closely observed for signs of PGO or asphyxiation.
So we have another question from Dr. Gentry D. Since the patient was intubated, could it be the balloon of the ET tube adding to the problem of retrieval?
Oh, definitely, sir. That further constricts the lumen that for which the tumor would be passing through. Oh, on clarification, the balloon was actually tried to be deflated during extraction, but it still did not push through. Sorry. So, yeah,
May we now call on Dr. Santi for any further questions or inputs?
Right. Good evening, everyone. I want to thank you, all of you, for inviting me to be a reactor for today. So I want to congratulate the PGH team. It's a very nice case, very well presented. Your slides are good, and your endoscopy video is very good. I was just curious. There are a few points that I'm going to be asking a few questions, but I was just curious first. Did you suspect that was a fibrovascular lesion from the onset? Because as you know, fibrovascular lesions are very rare in the esophagus. Or did you determine that it was a fibrovascular tumor or polyp because of your biopsy? Second, I'd like to address this question to Dr. Fragante. When you did the CT scan, was there any indication about the diagnosis of this lesion? Any indication that it was a fibrovascular polyp as opposed to it being another benign polyp like a leiomyoma? I also would like to there was a question raised earlier by Dr. Lazaro about whether or not endoscopic ultrasound would have been appropriate for this case. My opinion is that it's just too large a lesion, that endoscopic ultrasound would be very difficult in this case. And in the background, we were discussing this with Dr. Delutsong. It really is true that if you already know the diagnosis, you know that an endoscopic ultrasound might not be helpful. Another thing that I wanted to ask was, what was the thought process in trying to pull out the lesion proximally? We already know that this tumor is very large. It's 3 by 5 centimeters. We're not even including the stalk. Without any pathology, the esophagus in its normal state only dilates to about 3 centimeters. And especially if you have the upper esophageal sphincter to contend with, extracting a tumor this big would really be impossible. So I wonder if they thought about pushing the tumor into the stomach as their first choice of procedure. And again, yes, I agree with the question of Dr. Banyes. It would, or the comment of Dr. Banyes, it would probably have been better for them to just consider doing a piecemeal cutting or resection of the tumor once it was pushed down into the stomach. Then you really could have possibly extracted the lesion in the same setting. I also wondered why you thought that you would still find the tumor in the stomach after 2 days of leaving it there. Surely you would not expect a large piece of steak to still be there after 2 days. So I'm just a little surprised that people even thought that they would find the tumor there and that it was worth going in again. So, you know, it's just, maybe it would have been interesting really if it was there, right? And you guys just wanted to know, but did you really believe that you were going to find the tumor in the stomach? And that's it. So just a few questions, but overall, I like this case very much. I think it was a good thing to present to the group. There's a lot of learning in this case, and I'd appreciate some more cases like this really in the future. So congratulations to the PGH group.
Thank you, Ms. Andy. I'll try to answer some of the questions. First, I think the impression during the diagnostic endoscopy was, I think it's really a fibrovascular polyp, but they couldn't be sure, so they had to take biopsies. And this was confirmed, so the suspicion was confirmed through the biopsies. So we had the benefit of a histopathologic diagnosis of an FVP during the second endoscopy, which was actually the resection of the polyp. But I guess the more important thing here is to be familiar that fibrovascular polyp exists, that this entity exists in order for us to even suspect it in the first place. But again, we need a histopathologic diagnosis to confirm it. And yes, I agree that the EUS might be too large and might uh, too be too narrow for the esophagus to pass through. Uh, in terms of the attempt to retrieving the polyp proximally, yes, the esophagus is really that narrow. So it also was considered to push the polyp instead distally to the stomach, but even attempts at this maneuver failed because of the size and the shape of the polyp, which is like a gourd. So we couldn't push the polyp distally to the stomach. The piecemeal approach to resecting the polyp was considered, but it was deemed too long to take for the polyp to be resected adequately for it to be pushed or pulled upward. So it was eventually not considered. It would take around 30 minutes per attempt at piecemeal. It would take several pieces for this tumor to even be a formidable opponent, if you will, at being pushed or being extracted.
Excuse me, Joshua.
So,
You were
yeah.
eventually able to push the lesion in the stomach, correct?
No, we were not.
We were not able
not.
to push the stomach.
You're not able to do it at all.
Yeah.
Oh, I thought that you were successful in pushing the lesion into the stomach. So it stayed in the esophagus.
Yes. So
Okay.
we were
But then
we
my
were
point
banking.
about it still being there, was not valid because it never made its way into the stomach. I thought that you had been successful in pushing the lesion into the stomach. So it stayed there for 2 days. No, it stayed there until you did the endoscopy again and you didn't see it anymore.
Yes. So we were banking on the principle that being devascularized and completely resected from its stalk, it would eventually necrose and shrink, and eventually pass through the stomach.
All right, thank you. Could we get a comment regarding the CT? Do we still have Dr. Fragante on?
Yes, you're asking if how to compare, for example, with another benign tumor such as leiomyoma.
Yes, Dr. Could we have possibly been able to diagnose this just by CT scan?
Because of the large size of the tumor, actually it's going to be difficult to differentiate it from a leiomyoma. But usually leiomyomas are smaller. They're at least 5 centimeters or smaller. And usually we see them as thickening of the wall itself, which are smooth, unlike this case, in which you actually have a sort of attachment. And also in leiomyomas, you see calcifications that we did not see in this case. So when I saw this, it looked like a polyp to me, but I could not rule out the leiomyoma just because of the large size. I couldn't see the real focal thickening at the posterior aspect of that esophagus.
Yeah, and to add to Dr. Fragante, I think this is also where the EUS can also play a role in diagnosis, because we know that FVPs originate usually in the mucosa to submucosal layers, while leiomyomas are intramural, so they are muscular and they're the muscular layer of the esophagus.
Sorry, can you repeat that?
This is where differential diagnosis can also be distinguished using an EUS, ideally probably for smaller tumors, because we know that FBPs, based on their description and their pathophysiology, they originate usually in the mucosal to submucosal layers. So they can be seen on EUS as originating from these layers, compared to other differential diagnoses such as a leiomyoma, which can be seen on the muscular layer. So they are intramural.
All right, thank you.
Well, thank you, Dr. Pradigalidad and Dr. Fragante for all your inputs. May we hand over the mic to Dr. Grace Santi.
Hi, good evening. Congratulations on this interesting case. It was an excellent presentation. It was concise. I guess one of the take-home lessons in this case is the importance of preoperative assessment and planning. The team was able to set different plans on how to remove the large lesion. Di ba, you prepared a snare, you prepared several accessories like the knives, no, for you to be able to do ESD. However, preoperative assessment is not only limited to extirpation of lesions. Retrieval of lesions also need to be planned, especially when dealing with large lesions like this. And I just would like to ask if you did consider creating cleavage on the lesion itself just before completion of the mucosal resection. I understand that the smallest diameter of the snare you used was 3 centimeters. The smallest diameter of the lesion is 3 centimeters. It's 3 by 5, right? And the snare available is 3 centimeters in size. It would be really difficult to wrap that snare around a lesion of the same size. So if you put a cleavage on the lesion, then you may anchor that snare into that cleavage and be able to grasp the lesion more securely during retrieval. I also agree with Dr. Banyes on the use of overtube in this case, because the lesion might get trapped at the level of the upper esophageal sphincter during retrieval. Ano ba ba? And ang isa pang question, did you close the mucosal defect? How large was the mucosal defect? Because I wasn't able to appreciate it on the video. That's all.
Hi, we didn't close the mucosal defect. We did coagulation on. Then there was no vessel or perforation that occurred post excision.
So the muscle was intact.
Yes.
Okay.
So thank you, Dr. Santi. So now let's move on to the next case. To moderate the second case, we have Dr. Rafael Chan and Dr. James Montesa.
Good evening. Thank you, Dr. Rajaja and Team PGH for the nice, interesting case and for being the Goliath. We will now proceed with the presentation of Manila Doctors Hospital. There will be 2 short cases. Hello. Both of which has esophageal strictures, but different approaches in the management. So same house rule. If you have any questions, clarifications, please click on the chat box and type in your questions there. So we will do our best to ask all the questions written. So Dr. Alec Tan, the mic, the screen are yours. You may start now.
So hi, good evening everyone. I am Dr. Michael Alec Tan, a first-year gastro fellow from Manila Doctors Hospital. So I will be presenting the ERC case for our institution. Now for this evening, we have the following objectives. Our patient is a 57-year-old female with no known comorbidities. Sorry. Do you see the screen already? Sorry.
Go ahead, Mike.
Okay.
Go ahead.
Sorry
Go
for
ahead.
that. Our patient is a 57-year-old female with no known comorbidities. The patient is a case of a status post distal esophagectomy and proximal gastrectomy with pyloroplasty and tube jejunostomy, secondary to villus adenoma in a background of Barrett's esophagus, done in a different institution in 2018 under an attending surgeon. So patient came to our institution with a chief complaint of dysphagia. So in December of 2018, the patient underwent the said operation in another institution. Patient tolerated the procedure well and discharged with a jejunostomy tube. 1 month post-op, the patient started complaining of postprandial vomiting and dysphagia, described as difficulty swallowing solid foods, but still able to tolerate liquids. There were no other subjective complaints. So patient followed up with her attending surgeon who requested for an esophagogram. Now the esophagogram showed a normal esophageal diameter with post-operative changes. There was also a momentary pooling of contrast in the distal esophagus at the level of T11 to T12 and a small diverticulum in the distal esophagus. Patient was sent home by the surgeon with PPI and prokinetics. 1 year and 3 months prior to admission, patient was admitted due to an infected jejunostomy. So the jejunostomy tube was removed and patient was given antibiotics. While admitted, there was persistence of dysphagia at the level of the xiphoid and episodes of postprandial vomiting. Patient was then referred to gastro service for EGD and possible dilation. Now, EGD was done. The scope was inserted up to 37 centimeters from the incisors, where a narrowing of the lumen was noted. We were unable to pass the scope beyond this point. The esophageal mucosa grossly appeared normal. There were no nodules, ulcerations, or erythema noted. The scope was changed to a transnasal gastroscope and was able to pass through the narrowing. Retroflexion was done. There were no nodules and ulcerations noted at the other side of the stricture. We then proceeded with the dilation of the stricture. Now, a stiff guide wire was inserted through the scope channel and left in place after withdrawal of the endoscope. We proceeded with the dilation using the Savary-Gillard dilator from 9 millimeters to 15 millimeters. Now, there are two main types of dilators, the serial dilators and balloon dilators. Serial dilators, also known as bougie, are of gradually increasing diameter. The Hurst-type dilators have rounded tips. The Maloney type and the Savary-Gillard dilators have tapered tips. These are better at engaging narrow segments, thus are more widely available. Catheter-mounted balloon dilators can be passed through an endoscope accessory channel and allows graded distension over a range of 3 incremental diameters using pressure gauges to control the degree of distension. Now, going back to our case, post-dilation, we were able to pass a gastroscope through the stricture with ease. There was minimal bleeding of the esophageal mucosa, and the patient was stable with no immediate complications noted, such as bleeding, chest pain, or vomiting. She had episodes of reflux symptoms and was given PPI and prokinetics. Patient was able to tolerate regular diet thereafter and advised for nutritional upbuilding. Now, in April of 2019, a month after the dilation, she had recurrence of symptoms. Patient began experiencing dysphagia and vomiting of previously ingested food. So patient sought consult from attending physician. Upper GI series was done. Now, upper GI series done showed the proximal esophagus with slightly dilated caliber measuring 3.2 centimeters with narrowing at the distal esophagus measuring 0.8 centimeters. Now, there was a pooling of contrast in the distal esophagus noted. Other findings included a diverticulum in the distal esophagus and normal peristalsis. Now for
Sir Mike, can you please launch the first poll? So if you were the attendant physician, what do you plan to do to this patient? Do you do dilatation using bougie? Or you do dilatation you are using CRE balloon dilator? Or insert an esophageal stent? Or refer to surgery service? So to everyone, kindly participate. Thank you. Okay, sir, can you please show the result? So it's almost a tie between doing dilatation using CRE balloon and inserting an esophageal stent. The rest do dilatation using bougie, and very few, about 2%, will refer to surgery service. So Dr. Alec, you may proceed now.
So based on the above findings, recurrence of the distal esophageal stricture was considered. Patient was advised to have EGD done for further evaluation. Now, EGD was done. The scope was inserted up to the level of 37 centimeters from the incisors. There was note of a narrowing of the lumen, measuring about 3 millimeters in diameter, and the mucosa proximal to the stricture was smooth with no noted bleeding, ulcerations, erythema, or nodules. Through the scope, CRE balloon dilator was inserted together with a loop guide wire bypassing the stenosis. The balloon was inflated to 16.5 millimeters at 3 atmospheres for 1 minute, then 18 millimeters at 4.5 atmospheres for 1 minute. Now, post-dilation, the scope was inserted beyond the stenosis with ease. We then proceeded with the stenting. Now, a loop guide wire was inserted up to the antrum with 2 loops inside the gastric lumen. Using the guide wire, a partially covered self-expanding metallic stent, 10 centimeters in length and 20 millimeters in diameter, was inserted under fluoroscopic guidance with good positioning and expansion. Now, stents are commonly indicated for palliative management of patients with malignant strictures. However, successful application of metal stents for palliation of esophageal malignancies indicated that there might be a role for these devices in the management of recurrent benign strictures. In principle, the placement of self-expanding stent for a refractory stricture potentially allows the remodeling of the stricture around the stent with a more permanent benefit than dilation alone. Now, there are 2 main types of stents, namely the self-expanding plastic stents and metallic stents. The metallic stents could either be uncovered, partially covered, or fully covered. The newer type of stent is the biodegradable stent, which will be discussed later on. Post-procedure, patient was stable with no immediate complications noted. Patient was able to tolerate regular diet and was sent home. She was advised nutritional upbuilding prior to the planned removal of the stent. The self-expanding plastic stents are usually used for benign esophageal strictures, mainly as a temporary measure. They are safe and easy to remove with no risk of tumor ingrowth. However, there is a high risk for migration, and the application could be quite challenging because it requires a complex and stiff stent introducer system. Plus, they have a high rate of stent failure requiring intervention. The self-expanding metallic stent has 3 main types. So the uncovered metallic stents are indicated for patients who are expected to have poor survival and high risk for migration. These stents have the least chance for migration. However, they have a high risk for tumor ingrowth and they tend to be difficult to remove. The fully covered metallic stents are indicated for patients with high risk for tumor ingrowth. The polymer coating of the stent prevents ingrowth. These are also used for benign strictures and serve as temporary measures in anticipation of removal in the future. However, they have high risk for migration. The partially covered metallic stents are indicated for patients who are suitable for fully covered stents, but with high risk of migration. So these stents have exposed metallic parts in the distal and proximal ends of the stent. These stents have intermediate risk both for tumor ingrowth and migration. Now, on the interim, patient had several episodes of regurgitation and epigastric discomfort, but she was still able to tolerate regular diet and had good appetite. Patient was managed with PPI and prokinetics with improvement of symptoms. She was also advised to increase oral food intake and nutritional buildup with plans of stent removal provided that there is improvement in the patient's nutritional status. So patient was apparently well until 1 month prior to admission. Patient started to have progressive dysphagia, initially to solid foods, followed by postprandial vomiting. This was associated with a weight loss of around 3 kilograms in 1 month. No consult was done at the time due to the COVID community quarantine, so patient opted to observe the symptoms at home. 1 week prior to admission, there was progression of symptoms, now with difficulty in taking liquids until she could tolerate only a half of glass of water. So this prompted consult and the patient was admitted for further evaluation. Now, physical examination was generally unremarkable except for the low BMI. And here are the salient features of this case. Now, upon admission, the primary impression was a recurrent anastomotic esophageal stricture. So upon admission, an upper GI series was done, showing no significant change in the slightly dilated caliber of the proximal esophagus, measuring 3.3 centimeters, but now noted with a narrowing of the mid-esophagus, measuring 0.3 centimeters, proximal to which there was a pooling of the contrast. Then the previously inserted esophageal stent can be visualized at the same level when compared to the previous. These findings were suggestive of a stricture. The previously seen narrowing of distal esophagus was not well delineated in this study. So based on these findings, the patient was advised to have EGD done.
Hello. So we have a poll in progress right now. Can you please show the poll?
Okay.
Okay, so can we show the poll, please? Okay, I think we're having some technical difficulties. Alex, can you resume?
Yeah. Okay, po. So EGD was done. Upon insertion of the scope, there was a note of a narrowing of the lumen at the level 33 centimeters from the incisors, precluding further insertion. Mucosa was nodular and firm, and the previously inserted stent was not yet visualized at this point. So a transnasal gastroscope was then inserted in an attempt to bypass the stenotic area. However, it was unsuccessful. Next, a regular gastroscope was reinserted. We then proceeded to do through the scope wire-guided balloon dilation under fluoroscopic guidance. Now, a loop guide wire was inserted with 2 loops inside the gastric lumen. The CRE balloon was inflated to 1.2 centimeters using 3 atmospheres for 30 seconds with adequate dilation. Gastroscope was thereafter able to pass beyond the stenosis. The stenosis was noted about 2 centimeters in length above the proximal end of the previously inserted metallic stent, which was still in place. Multiple biopsies were taken. Now we proceeded with inserting a partially covered metallic stent, 8 centimeters in length, using a controlled release distal type deployer, in this case, the evolution stent. Now, there are 2 main types of stent delivery system. The distal release system releases the stent from distal to proximal. It allows the elimination of proximal foreshortening during deployment and is best suited for stent placement in the middle and upper esophagus. The proximal release system releases the stent the opposite direction from proximal to distal. So this type of delivery system allows elimination of the distal foreshortening during deployment and is best suited for stent placement in the gastroesophageal junction. Now, the evolution stent uses the distal release system. It has a pistol grip mount, controlling the release of the stent by squeezing the trigger. Each trigger squeeze deploying the stent by an equal amount. Now, if repositioning is needed, it is possible to recapture the stent. Positioning of the stent can be confirmed using fluoroscopic guidance. Now, going back to our case, the stent's distal end was positioned overlapping the proximal part of the previous stent. The position was confirmed by fluoroscopy, then stent was deployed. Once the point of no return is reached, indicated by the red arrow, so the safety wire can be removed completely and proceed with releasing the stent until it is completely deployed. Now, the patient tolerated the procedure well. Post-procedure, patient had episode of chest discomfort and regurgitation, which resolved after given pain medications, PPI, and prokinetics. She was eventually progressed to regular diet and was sent home improved. Biopsy results showed acute and chronic esophagogastritis with granulation tissue, pointing towards a benign etiology of our case. Here is the final diagnosis for this case. Now for our discussion, the esophageal strictures are abnormal narrowings of the esophageal lumen, often presenting as dysphagia. They could either be benign or malignant, and incidence of esophageal stricture was 1.1 per 10,000 person years and increases markedly with age. Peptic strictures are the most common cause of strictures, which develop from long-standing GERD. These strictures account for 70 to 80% of adult cases. Endoscopic dilation done 1 to 3 times and treatment of underlying causes will resolve strictures in most instances. However, despite treatment, the rate of recurrence was 11.1 per 100 person years. So for this discussion, let us focus on the benign anastomotic strictures. Anastomotic strictures occur in post-operative patients and present as a narrowing at the level of the esophageal anastomosis. So they are usually secondary to tissue ischemia, leakage, radiation therapy. These strictures develop in 5 to 46% of patients after surgical resection. So refractory anastomotic strictures that occur after gastrointestinal surgery are common with a reported incidence of 2 to 30%. In the management of benign esophageal stricture, dilation is still the mainstay of therapy. So many patients with mildly stenotic lesions do not complain of dysphagia, which develops only when the esophageal lumen is substantially compromised. Modalities in managing strictures include dilators, stents, and some novel modalities that will be discussed later. As noted earlier, stents are usually used in malignant strictures. The most recent meta-analysis was conducted by the European Society of Gastrointestinal Endoscopy in 2015, showing an overall pooled clinical success rate of stent placement of 40.5%. Guidelines recommend consideration of fully covered metal stents in refractory strictures after other measures have failed. So stent placement should be temporary to avoid hypertrophy at the upper and lower margin of the stent. In cases where hypertrophy has occurred and the stent cannot be easily removed, a stent in-stent technique can be used to induce pressure necrosis of the hypertrophied tissue and removal of both stents after 2 weeks. Now, a relatively new development are the biodegradable stents. So they are made of polydioxanone, which are degraded by hydrolysis about 8 to 12 weeks after placement, but maintains its radial force over time. The main advantage of these stents is that they do not need to be removed. In the ESGE meta-analysis, those treated with plastic and metal stents did not report significantly higher success rates than patients treated with biodegradable stents. So the prolonged dilatory effect before stent absorption and the progressive stent degradation could represent a more favorable solution for refractory strictures compared to that of metal and plastic stents. They can be considered early in the course of treatment if serial dilations would not be possible because of compliance or nutritional issues. Now, complications associated with esophageal stents are generally classified as either early or delayed. Now, early delay complications occur immediately or within 2 to 4 weeks post-procedure and can occur up to 32% of patients. Delayed complications are more common and occur at least 4 weeks, even months after placement of a stent. They can occur up to 53 to 65% of patients with a reintervention rate of up to 50%. For benign strictures, the most common complication is the ingrowth of benign granulation tissue through the stent mesh. which starts to occur as early as 2 to 6 weeks after stent placement. Now, ingrowth of granulation tissue resulted in recurrent obstruction in up to 40% of patients. Several studies have looked at possible adjunctive methods in managing strictures. Now, chronic inflammation leads to collagen deposition in strictures. Steroids has been shown to augment the effect of endoscopic dilation of strictures of varied etiologies. Another agent, the mitomycin C, is a chemotherapeutic agent that inhibits DNA synthesis through cross-linking. However, more experience and more powerful study designs are needed to determine whether mitomycin C or other agents offer an advantage over continued dilation. Now, another potentially more appealing approach in managing anastomotic strictures is to directly incise or cauterize the fibrotic section. Thus, incisional therapy using needle knife has gained popularity. Case
Uh,
report. Yes,
Sorry, Alec, before we go further, there are some questions regarding the first case.
sorry.
So let me ask our reactors, either Dr. Prodigalidad or Dr. Santi may answer some of the questions here. A question from Dr. Manli Uy: how long can we leave a metallic stent in place?
I thought I was just a reactor, Rafi, not
I'm
somebody from
sorry.
else. But I
Anyway,
can answer. I
are you?
can
Do
help
you
you with
feel
that.
comfortable in answering it? If not,
It's fine,
I can
right?
just ask
So
our.
it depends on the purpose of your stent, right? If this were a malignant stricture, then you would really decide on leaving it there permanently, right? If this was just put in place because you feel that without the stent, when the after dilatation without the stent, the restructuring of the esophagus would lead again to another stricture formation, then you would leave the stent there maybe for about some studies will say up to 16 weeks, some say up to 8 weeks, but it's temporary and you don't leave it there permanently. I think the question that's most important really regarding this case is why did you feel that you needed to put a stent in so early in the course of this patient? Did you not consider just redilating?
The placement of the stent was offered to the patient because after the first dilation po, there was recurrence of the stricture after merely a month. So the the option to place a stent was offered to the patient, and the patient preferred to have the stent placed po, rather than coming back regularly for dilation.
May I speak?
Yes. Gracie, yes.
Yes, Doc. I actually have the same question as Dr. Sandy. Why was redilation not considered using maybe a 16 millimeter or 18 millimeter OG balloon was done? Kasi yung initial dilatation hanggang 15 millimeters lang. Anastomotic site strictures are often recalcitrant to therapy. They have very high rates of restenosis because of there's a component of ischemia and fibrosis. So I understand that it's quite frustrating for us GI and more so the patient. However, by definition, this patient did not qualify as having refractory benign esophageal stricture because by definition per se, RBES means persistence or recurrence of symptoms such as dysphagia despite at least five dilatations. I came across a study about a review actually in GIE published in 2017. It's quite old, and this study included patients with RBES only, and their data showed that although there was a bit longer dysphagia-free period in patients who got endoprosthesis compared to those who received balloon dilatation alone, apparently SEMS does not affect the long-term natural history of the disease. Kaya I'm curious why SEMS was the second was immediately done to this patient. Yun lang po.
Um, yes, po, Doc.
Okay, thank you,
For the
Sandy.
benefit of everyone, thank you, Gracie. That's 5 attempts at dilatation with 2-week intervals.
Yes, Doctora.
So none of that was followed in the case of this patient, and we decided to jump the gun. We decided to just, put that stent in. And I wonder if you had said or given the option to the patient, because putting a stent in is not without complications. And in the case of this patient, we realized one complication, and that's the stricturing because of the stent being there, no? Which then led to some more procedures requiring to be done. So the dilatation might be tedious to do, but the result in the end, if you are successful, is much better than the result if you probably had put a stent in.
Of course,
so yun lang. I just wonder why. Maybe next time.
It was
Okay.
considered, Doc. Sorry.
Okay, thank you, Dr. Sandy, Dr. Gracie, for your comments. We might be able to answer the question later. So for now, Dr. Alec, you may proceed with your second case.
Okay po. So the case reports and case series on the use of endoscopic incisional therapy for the esophageal strictures have been reported since the 1980s. However, overall experience is limited and mostly retrospective. So one such procedure was performed in our institution to manage a case of a recurrent benign esophageal stricture. So this was a case of a 45-year-old male, known case of recurrent esophageal stricture, secondary to caustic ingestion. So status post distal esophagectomy with colonic interposition and gastrojejunostomy, managed with repeated mechanical dilation. The latest mechanical dilation was done just 2 weeks prior to admission, wherein the patient underwent dilation with several dilators with relief of dysphagia. However, patient came back with recurrence of strictures after only 2 weeks. The patient was then offered to have stricturotomy done. So EGD was done. A stricture was noted at the level of 15 centimeters from the incisors with note of fibrotic areas. We were unable to insert the scope through the stricture beyond this point. Stricturotomy was then done as follows. So a radial incision was done around the fibrotic area using a 1.5 millimeter flush knife. Several radial incisions were made around the rim of the stenosis. After the radial incisions were done, the parts of the strictured site in between the radial incisions were also sliced off using the knife. Now, endoscopic incisional therapy follows the same basic principle with dilation, which is the disruption or displacement of the fibrotic tissue to help restore a satisfactory lumen diameter and prevent reorganization of the fibrotic tissue. Now, a needle knife is basically a naked diathermy wire used to incise fibrotic tissues. So this technique entails radial incision and cutting of the stenotic rim of the stricture in order to achieve adequate lumen diameter. Now, after adequate incisions were made, we proceeded with inserting a guide wire followed by a balloon dilator through the stricture. So the balloon was inflated to 1.5 centimeters at 8 atmospheres for 1 minute. Then after balloon dilation, the scope was able to pass beyond the stricture with ease. So there was no significant bleeding noted. So most studies on incisional therapy were done on anastomotic strictures. A study with 20 participants was done on persistent anastomotic strictures even after the 3 endoscopic dilations. So these patients were treated with a session of needle knife until a regular endoscope could pass through the stricture. 12 patients became free of dysphagia after one treatment. The remaining 8 patients required an average of 3 electrocautery sessions before they became symptom-free. Randomized prospective study compared it with a serial guide wire-directed dilation. They concluded that incisional therapy was equivalent but not superior to dilation.
Sir Mike, can you please launch the last question, please, the last poll? So what would you do if the stricture recurs? One is to do mechanical dilatation, two, repeat stricturotomy, and third is to refer to surgery service. Okay. I think it's more than enough. So more than 50% answered mechanical dilatation. Some refer to surgery and others will do a repeat stricturotomy. So Alec, you may proceed.
So the complications for this procedure are similar to that of other mechanical management of esophageal strictures. So perforation is the most dreaded complication, ranging from 0 to 3.5%. These can occur because of the inability to gauge the depth of the esophageal wall or the length of the stricture during the incision therapy. So bleeding is usually self-limited and a lesser known complication, as a fibrotic stricture subjected to incisional therapy are relatively avascular. So if bleeding were to occur, it can easily be managed by balloon tamponade. Then complication rates appear to be mild, comparable to dilatations or with bougies or balloons. So in summary, dilation is still the mainstay of therapy for benign strictures. Temporary placement of stents can be done in benign strictures. Incisional therapy provides a potential alternative to repeated dilation in recurrent esophageal strictures. No novel techniques in the management of strictures are limited by their lack of large-scale trials. So these are my references.
Thank you, Dr. Alec, Team Manila Doctors, for the nice presentation. I will turn you over now to Dr. James Montesa for further questions and answers.
Okay, thank you,
James,
Dr. Chan.
please.
Thank you, Dr. Yes, Dr. Yes, thank you, Dr. Chan and Dr. Alec. Thank you for a wonderful and concise presentation. Before we go to our reactors, we'll answer some questions first. From Dr. RG, was SEMS considered on your second case, Alec? SEMS
For
placement?
the second case?
Yes, the stricturotomy.
The problem with the patient with the stricturotomy is that the location of the stricture is very high up in the esophagus. It is 15 centimeters from the incisors. So putting a stent in that area might cause the patient to have symptoms of foreign body sensation at that area and globus sensation. And also the placing of in the upper esophagus could lead to, and the upper esophagus is known to have associated with more complications, such as it is possible that for the rate for yeah, perforations is higher in the upper part of the esophagus.
Okay, thank you, Alec. Regarding the first case, Alec, was there any attempt to reposition the first SEMS?
The first SEMS was when the placement of the stent was compared with the previous previous X-ray done, and it was noted that there was no stent migration that occurred. So That's why they did not. It was not considered to be repositioned po.
Okay, so that is also to answer the question of Dr. Gentry. So the stent did not migrate.
Yes po.
Okay. So are there any more questions from our guests? Okay, so may we now proceed with our comments from our reactors. May we now start with Dr. Grace Santi for their comments. Dr. Grace Santi.
James, I think Dr. Gracie left already. Maybe
Okay.
ask Dr. Sandy.
Dr. Sandy, do you have any comments or reactions?
Well, I wanted to say again, congratulations to the Manila Doctors Group. Again, a very interesting case and lots of learning to be taken from this case. I think, again, we already discussed that we probably should decide or be careful when we decide regarding putting in a stent or just dilating again. Just for the learning of the other people, I would like to ask the presenter, you gave an oral kind of steroid, did you not, to the to the second patient? Did you give an oral steroid to the first patient? I also would want to ask if, do you think the oral form of a steroid is best to prevent recurrence of stricturing? Or do you think there are other ways of applying steroids in the case of your patient? And also, if you decide to take or to give your patient steroids, would you know which patients with esophageal strictures are actual candidates for steroid use or application?
Okay po. Doctor, I would like to address the question earlier regarding the patient after the first dilation and the patient had a recurrence of the stricture. The patient asked about the prognosis of the case, having the stricture occur only after a month after dilation. So it was explained to the patient that given there is a possibility of repeated dilation. So that's why she asked for an option wherein if it is possible to have if there an option to lessen the repeat to prevent that or to avoid repeated dilations. So that's how they came to offer having the stent applied. And regarding the application, the oral steroids food, doctor, both patients were not given oral steroids.
I think I saw prednisone in your medications.
I think, is this the one?
The last case.
This slide po. This is the second case po.
Alec, I think Doctora is referring to the second case when the patient was the patient given oral steroids for the second case? Prednisone?
There was no prednisone.
Can you scroll down? No, there was. But I'm sure it was not my imagination. I
I'm sorry,
saw
doctor.
oral prednisone somewhere. But in any case, regardless whether you gave this patient prednisone or not, what is your opinion? And in your readings regarding this case, what would be your opinion regarding steroid use? And in what setting would it be appropriate?
The steroid use are usually, most studies that I came across were intralesional injection of the steroid during dilation po. There was there was not much mention of oral steroids given to the patients. So for this patient, since the patient already has a recurrent stricture for the past 10 years, so I think we could try trying intralesional steroids for this patient po.
I think what I was hoping for you to say so that the others may hear is that the steroid injection is not applicable to all kinds of strictures post-dilatation, right? Because they would not likely work in anastomotic strictures because, as pointed out earlier by Dr. Santi, the pathology behind it would be ischemia, right? And fibrosis there, developing fibrosis. The intralesional steroids would usually work better in strictures that have developed because of inflammatory processes, such as peptic strictures, and maybe in the case of a caustic injury. So I think that was all that, that I wanted for the others to hear.
Okay, thank you very much, Dr. Stanley. Are there Andy?
So I have. Were you asking me?
Yes, ma'am.
Oh, yeah. No, actually, still overall, I would say that it was a very good presentation. So I want to again congratulate the Manila Doctors team. Thank you.
Thank you, Doctor.
So I think that's it for the questions. So thank you to all our presenters from PGH and Manila Doctors Hospital, and to our reactors, Dr. Santi and Dr. Padrigalidad. So before we close our second ERC, we would like to call our sponsor from ISI, the Senior Product Manager, Mr. Marty Dizon, for some words from our sponsors.
Thank you very much, Doctor. Again, good evening, everyone. First of all, I would like to congratulate our presenters this evening, UPPGH and Manila Doctors Group. It was a very interesting cases. And again, this is Marty, the Senior Product Manager handling Pariet and Gasmutin from HISI. So it's a human healthcare company, and we give first thought to patients and their families to increasing the benefits healthcare provides. And again, in behalf of HISI family, we would like to thank Philippine Society of Digestive Endoscopy for again giving us this opportunity, great opportunity to be your partner with the endoscopic radiologic conferences. Again, maraming salamat po.
Thank you, Sir Marty. So to formally close our conference, we would like to call on our Vice President of PSDE, Dr. Julius Cosoriano. Dr. Julius, the mic is yours.
Yeah, good evening to all the audiences. First of all, I would like to thank our able reactors, Dr. Sandy and Dr. Santi, and our radiologist.
Reminder niya.
And then thank you, UPPGH and MADOX for sharing your cases. And to the moderators and presenters, thank you. And to our sponsors also, HISI. Let me just announce to you our next event which will be on July 22. We have the PSD webinar series. It's about basic this one is okay. It's about the basic endoscopic ultrasound, which will be on July 22. That's a Wednesday. No, 6 p.m. to 7 p.m. And the next one will be the next ERC, which will be on August 6th. It's a Thursday, which will be presented by De La Salle University and Makati Medical Center. So I think we had a fruitful night tonight. We thank you all for coming and attending. With that, good night to all.
So thank you, Dr. Julius Soriano. So that ends our ERC for tonight. Good night to everyone. Thank you.